From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
Hello and welcome to our listeners from around the world. You're listening to JAMA Neurology Author Interviews. Thanks for joining us. I'm Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology Web Editor. Today, we are discussing treatment of acute ischemic stroke. Dr. Colin Derdeyn is joining me today to discuss his original investigation entitled Intravenous Argatroban and Eptifibatide in Patients Undergoing Mechanical Thrombectomy. Dr. Derdeyn is a professor and chair of radiology and medical imaging at the University of Virginia School of Medicine. He is a physician scientist and interventional neuroradiologist specializing in endovascular treatment of neurovascular conditions. Dr. Derdeyn, welcome to the podcast.
Thank you so much, Dr. Armand. It's a great honor to participate, and I'm excited to discuss our work.
Yes, whenever it comes to the topic of stroke management, it's very exciting because we've had so many advancements. I mean, even when I was in training, what was done then to what is done now has just really improved stroke outcomes and really helped with secondary prevention as well in terms of how people should live. What really inspired you in terms of this topic? I would imagine is what you do every day and what you see.
It's been such a privilege to see over the arc of my career where we started when I began, which was the revolution of intravenous tissue plasminogen activator, or TPA, for acute stroke patients, which was really transformational. We had something that we can do to actively improve patients that came in with real deficits. Numbers needed to treat for IV-TPA, though, still had to treat, I think it was about 7 or 8 patients to see an improvement in neurological outcome. But things stayed relatively static for decades. And then we had this revolution in thrombectomy, which came along about 10 years ago. And that required iteration of devices. It required wide availability of advanced imaging in the emergency rooms, CT-A and CT perfusion to select patients. And it really built on these systems of care that IV-TPA helped to create: comprehensive stroke centers and AHA certification and Joint Commission. Built on that platform, we saw about a decade ago several trials that came through that showed unbelievable efficacy. Numbers needed to treat of 2, where we would have patients that came in and still have patients that come in hemiparetic, aphasic, that Lazarus-like on the table regain those functions when you remove the large vessel occlusion. So extremely powerful and gratifying and impactful. Even though about, I would say, something close to 40 to 50%, depending on the study, of patients have real improvement with thrombectomy, a large proportion of these patients don't. They are left moderately to severely disabled after a large vessel occlusion, even if we get the blood vessel open, which we do with thrombectomy, either a suction thrombectomy procedure or a stent retriever that pulls the clot out. That's really where we're focusing now in the field, which is patients that, despite successful thrombectomy where we remove the clot, they don't recover well. And there's a long list of reasons for why that happens. That includes the infarct has already completed and there's nothing there to save. There's apoptotic mechanisms where triggers have been triggered where the cells are going to go on and die anyway, even if we reperfuse, even if they're alive. But then there are some other causes too, and that's where this study in particular comes in, where we have distal emboli. So we do a thrombectomy, and there are small fragments that break free that go further downstream and plug up smaller vessels. And can pharmacological adjuncts, can medicines like Argatroban or Eptifibatide, which were the 2 drugs in this study, do they help? If we add those to a routine thrombectomy, do those patients have better outcomes because these distal emboli lyse more quickly or they don't propagate? Other mechanisms as well that we're thinking about has to do with the microcirculation, which we don't see on an angiogram, where small debris gets down into the smaller capillary level or arteriolar level. And these agents may help improve perfusion at that level as well. And there's some good reasons to think from cardiac studies that that's something that could happen. And then the final way that these drugs could improve the outcome from a thrombectomy procedure is by making that procedure just more effective, that we're able to get more complete reperfusion of that target occlusion with these agents on board. And these agents have been shown to improve recanalization rates and outcomes in acute MI, which again was really the basis for why we pursued it.
So it's remarkable that we can look at what's happening during an ischemic stroke and what we already have out there in terms of treatment and say, how can we further enhance this? And I think using these two medications in this trial is a great start. Now, I'm sure you know this, but it's a fine line in terms of setting up a trial like this and enrolling patients. And there are nuances because we're dealing with essentially a serious medical event, essentially life or death situation. What was the setup of this clinical trial in this study?
Yeah, these trials are hard, and they are a real credit to the subjects and their families that are willing to participate, and to these acute stroke teams that can recruit, randomize, and enroll while things are moving in such a time-critical fashion. And a lot of different sites do it different ways, but it is a massive effort, and it's amazing that people do it so well. But many of our sites, this study was performed largely at StrokeNet sites, which is a network of NIH-funded stroke centers around the nation, where they have very functional, high-performing teams that perform those functions and make it possible to be able to test these super acute, time-critical interventions in this kind of environment. In terms of the trial design that you mentioned and how we did it, this was a pre-planned subgroup analysis of a randomized trial looking at the efficacy of these two drugs, Argatroban, which is a thrombin inhibitor, and then Eptifibatide, a 2B3A inhibitor, looking at those two drugs as an adjunct to intravenous fibrinolysis, either with TPA or with TNK or tenecteplase activator. But we knew when we designed that study that a very large fraction of these patients that were enrolled would go on to thrombectomy. And we wanted to evaluate whether or not these agents added anything to recanalization rates or outcomes in that subset. But the study was designed to enroll patients with acute ischemic stroke that were eligible for intravenous thrombolysis and to administer these study drugs in combination with the intravenous thrombolysis. And there were practical implications of that because of time pressure and real world events where a lot of these patients, they got their TPA as standard of care immediately and very quickly. The study drugs were not started at the same time as the TPA almost always, which ideally would have tested the hypothesis better in a way. But because of consent and pharmacy and all of these other things, the drugs could be started up to an hour and then I think 75 minutes after TPA infusion. But there was some delay in study drugs starting relative to the start of TPA or TNK.
You said, if I got that correctly, most of the patients in the study did undergo thrombectomy?
It turned out that 40% did. 40% of these patients went on to thrombectomy.
Okay. So pre-planned trial, patients were getting standard of care, but this further enhancement of treatment was incorporated to answer our question. Can you tell us more about your design, how many patients, what were the arms, and also the outcomes we were looking at?
The design of the primary study, the study that was originally published, which was the MOST trial, that was looking at the overall outcomes of a large cohort of patients that were seen within 3 hours of stroke symptom onset, got IV lytic as part of standard of care, and then got study drugs. And there were 3 arms to this study. There were patients that got the TNK, TPA alone, plus a placebo, so this was a placebo-controlled trial, or Argatroban, a direct thrombin inhibitor, or Eptifibatide, which is the 2B3A inhibitor. So there are three possible arms for these patients. Within that group, 40% of those enrolled patients went on to thrombectomy as part of standard of care. And that came out to a total of about 250 patients total that went for thrombectomy within the MOST trial. They were randomized to placebo with about I would say, 40% of the patients. Eptifibatide was about 40%, but then Argatroban arm was only about 20%. And the reason for that was the study used a response adaptive randomization protocol that started to preferentially put patients into arms where there was a greater chance of success based on ongoing analyses of outcomes. And that was probably related to several bad outcomes in the Argatroban arm that drove the statistics of that. So the study is a little limited in what it can say about Argatroban particularly, but Eptifibatide and placebo were pretty even in about 40% each. The primary outcome for our study, this pre-planned study of outcomes in the thrombectomy arm, was, first of all, the clinical outcome, which was a utility-weighted modified Rankin. So the modified Rankin, as you know, is this 6-point scale of disability with 0 being normal and 6 being dead. The utility weighting expands that to 10 points. So it gives it just a little bit more range and granularity. And there's some good data that is a little bit more of a sensitive indicator of outcome than the original modified Rankin. So that was our outcome scale. We also looked at recanalization rates with the thrombolysis and cerebral infarction TICI score, the TICI score, where a TICI score of 0 is no reperfusion and a TICI score of 3 is a complete angiographic reperfusion. And then safety was also another endpoint that we evaluated because we're adding powerful antithrombotic or antiplatelet agents on top of a fibrinolytic agent in patients undergoing an endovascular procedure in their head for stroke. So safety in terms of groin access, but also intracerebral hemorrhage was a real concern.
And did you have some secondary outcomes that you looked at that would be relevant here?
Well, the primary outcome was the utility-weighted modified Rankin. And reperfusion rates and safety were the secondary.
Those were your secondaries. Okay,
yes.
Got it. Now, tell us about what you find. Was there further enhancement with these medications?
So what we found was that adding these agents did not improve neurologic outcomes. They were the same as placebo. And they also did not improve recanalization rates either. Finally, they were safe. We did not see any indication that there was an increased rate of bleeding. There was a numerical increase in bleeding, particularly in the Argatroban arm, but the numbers are so small, it's hard to make anything of those. And those patients came in with larger strokes, which may have been why they had worse outcomes and may have impacted the randomization scheme. So there's a lot of reasons for that, but ultimately safe. So the bottom line was that these drugs did not contribute or did not help drive better recanalization rates or clinical outcomes in patients that go on to thrombectomy.
Where would you go from here? Because the reason for this study, I think you had excellent reasons in improving those end vessel emboli that may occur. Would we design a study that had more participants or different doses? Obviously, not going into futility here. What are the next steps?
There's a lot of next steps that come out of this. First is that we think that it's highly likely that adding these agents to this population where they're already getting a powerful thrombolytic may not add much value. So this population that gets IV TPA or TNK and having these agents added right at the same time For patients that are going thrombectomy, there probably is very little additional benefit, if any, to add these agents. They're safe, but there's probably no real benefit. Larger numbers could show a very small effect, but that's probably not meaningful.
And that makes me feel good to hear, right? Because what we're doing is seemingly adequate in terms of improving our patients' outcomes.
That's right. Now, there are a large number of patients that come to thrombectomy that do not get fibrinolytic therapy because they present later. So they come in after 3 hours or after 4.5 hours, which is, as you know, the time limit for getting a fibrinolytic agent intravenously. So we see a lot of patients that come in 5 or 6 hours after their stroke with a large vessel occlusion that go on for TPA, or they're transferred in and they have had TPA on the outset and it's been a while, it's 6, 7, 8 hours later. And those patients would not have been eligible for this trial, but they are thrombectomy patients. And there may be a value there. So adding these agents to thrombectomy in patients that are not getting a lytic agent, or it's been a while since they got it, there's a lot of reasons to think there's a benefit there. And in fact, there have been a number of trials now, other trials, that have tested this hypothesis of adding these agents to thrombectomy that have shown some benefit. And most of them have included large proportions of patients that did not get TPA or TNK, or they excluded those patients completely. And none of those patients in those studies got TPA or TNK. So that's an area that is very promising as well. And I think there's still some questions of dose, but adding these as adjuncts to thrombectomy procedure has a lot of potential. And the data's been mixed, but there's a good trend towards showing efficacy. And finally, the other avenue that's being actively investigated that also has a lot of promise is changing the route of administration and giving these agents inside the artery after the thrombectomy. And there's been a few studies that have shown benefit of doing that after thrombectomy, but again, largely in patients that go on to thrombectomy that did not get a lytic agent.
That makes a lot of sense, and it really opens up more options for these patients out of the window as well.
Yes.
Dr. Derdeyn, any closing thoughts here about your work?
Thank you so much for the invitation to discuss this work. I greatly appreciate it. These trials, as you know, require so much effort from so many people and from the subjects themselves. So the opportunity to discuss and talk and think about the impact of the study and what we learned from it and what the next steps are, that's really such a wonderful opportunity to do that. So thank you for that. And I am excited about the next steps. I think that this is not the end of these agents. We know that we can improve thrombectomy. Outcomes still are not as good as we would like them to be, despite our ability to get these blood vessels open completely and quickly. But so many of these patients really do not make the recoveries we'd like to see. And there are so many trials that are coming down the pipe, literally and figuratively, to help improve outcomes. So it's an exciting area with a lot of real potential benefit for our patients that come in with an ischemic stroke.
Dr. Derdeyn, thank you so much for joining us today.
My pleasure, and thank you.
I'm Dr. Cynthia Armand, and I've been speaking with Dr. Colin Derdeyn about intravenous Argatroban and Eptifibatide in patients undergoing mechanical thrombectomy. You can find a link to the article in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.